I'm Kathy English, the Chief Marketing Officer at Vocera, and I'll be facilitating this very important discussion about how we can support nurses on the front line. Around the world, nurses have been the face of the COVID-19 pandemic, stepping up in so many heroic ways to help patients and fellow colleagues in need. We need not only to praise them for their tireless work, but we must also give them the tools and resources they need and deserve to safeguard their physical, their emotional, and mental well-being. So with me here today to talk about how we can support the well-being and resiliency of nurses and other care team members is Dr. Rhonda Collins. Thank you, Dr. Collins, for joining us today to share your perspective and some valuable insights from your latest CNO report.
Thank you, Kathy. I really appreciate this opportunity to talk with all of you today. We have a lot to talk about. There's much to share, much to learn from each other as we move forward. Before this pandemic, healthcare workers faced a number of challenges that caused stress, emotional exhaustion, and yes, cognitive overload. The nurse's job has always been tough. Now it's being made even tougher by facing things we never thought we would face. Our patient doesn't get to see our face. Loved ones are not allowed inside the room with their very ill family member. Taking care of patients in beds that have been set up in boardrooms and in supply rooms. The constant need to don and doff PPE, the shortage of equipment, and all of the requirements that have been required of nurses and physicians as they have worked through this crisis. Then you add to that the fear of becoming infected with a novel virus or passing it along to family members has added even more anxiety to the healthcare workers on the front lines. And as I was writing my 2020 CNO report, I was really burdened in contemplating the toll on nurses and physicians who are working these endless hours, putting themselves in harm's way to protect us all. And now more than ever, we have to protect their physical and their mental and their emotional well-being of the care team members. And I think everyone who's listening probably feels a great responsibility for those who work in their organizations and have faced these crises and moving forward. We have to find ways to reduce their cognitive burden and truly protect their capacity to care. We will be lost without them. So each May, I write a CNO perspective report on a topic that's top of mind for nurse leaders. Last year, I wrote about reducing the cognitive load for nurses and other healthcare professionals. I've spent the last year speaking on the topic globally and publishing on this topic, published in Nurse Leader in February of this year. The response I've continued to receive from nurse leaders tells me that the theme of reducing cognitive burden is important and still quite timely. I felt a little out of place talking about something that clearly was not 100% consumed around the coronavirus and our response. But as I started to work through it, I realized that now more than ever, cognitive burden is more of an issue than it was before. The mental, emotional, and physical burden nurses must carry is tremendous. Every day, because of cognitive overload, a nurse makes a mistake. While we will be on this call getting this information, a nurse is going to make a mistake due to cognitive burden. I'm sure there's many of us listening in who would like a do-over for some of those mistakes that we've made. We carry the consequences of errors, large, small, and some of it stays with us forever. For those of us who know what it's like working in the trenches, it has no bearing on our education, our competence, or our ability to do our job well. It has everything to do with the environment around us and how we manage and parse information. I have spent a great deal of time talking about this topic, and I want to give us a definition of cognitive load or cognitive burden. The definition is the total amount of mental activity imposed on a working memory in any one instant. Working memory is the ability to remember and use relevant information while in the middle of an activity. Cognitive load is normal. That's the thing that we have to remember. Cognitive load is normal. I think that all of us can think about those times when we've been doing a critical task and all of our other senses were tuned in and we're crystal clear in the moment and we're able to deliver what we need to deliver. And then some of us can think of those times when we're having to do a critical task, but there is so much distraction because of so many different other elements in our environment that it makes it difficult to concentrate. What becomes overload is when what's coming into the individual exceeds the capacity of the person trying to process the information. An example of that in healthcare is, for example, nurses cannot control the amount of information, they cannot control the timing of the information, and they cannot control the means by which the information comes to them. They simply must stand in the meteor shower and absorb it and make sense of it, respond to it appropriately, or use that information for the good of the healthcare team or for the patient. Estimates indicate the attention span of most adults is from 5 to 20 minutes, but it can be as short as 8 seconds. So I'm going to guess that some of you are multitasking while you're listening into this. So that affects your ability to remember, to be able to take information and work from that, or your ability then to recall it at a future time. Just quickly before we go on to the next slide, there are 3 different kinds of cognitive burden. There is intrinsic, which is, I always refer to it as the backpack you can't take off. You know, it's the knapsack that stays with you. It's caring for an elderly parent. It's caring for a special child, or maybe financial worries or responsibilities. That goes with you wherever you go, and that creates a cognitive burden. In most cases, we just deal with it, we manage it. But then if you add extrinsic cognitive burden to that, you're adding in what the environment delivers to you. Some days you may show up at work and everything is organized and orderly, nothing's urgent, you're able to move through your day, so your cognitive load is very low. Other days, there's one urgent activity after another, or multiple tasks. So now you're adding your intrinsic load to your extrinsic load, and then you deal with the third component, which is the germane load. And that is how you make sense of what is around you, how you make sense of where you work and what you work in. So you add your own personal response of intrinsic, extrinsic, germane to our 8 core cognitive capacities. Everybody on this call has these 8 cognitive capacities. Some of us are highly developed in 1 or 2 of them, and some of us are not so well developed in others. But basically, the definitions for these: to sustain attention is the ability to stay focused on a task for an extended period. Some people have extraordinary capabilities in that area. I happen to be someone who struggles with that. I can listen for a short period of time, and then it's the reason I can't listen to audio books. My mind wanders. I have to be able to read the book and to be able to stay in the story. Response inhibition is the ability to shut out distractions and stay focused. The speed of information processing is how quickly someone can process written or spoken information. Flexibility and control is the ability to switch between thoughts. Multiple simultaneous attention is basically multitasking. Working memory is the ability to remember and use relevant information. Category formation is the ability to organize information. It's your own personal filing system. I have all this information, now how am I going to slot it so I can remember it for use in the future? And pattern recognition is the ability to recognize patterns and anticipate what's going to happen next based on that pattern of behavior, that pattern of response, that pattern of a patient's signs or symptoms. Can I predict putting that together with my knowledge and my ability to take this information and use it in the moment? In my report last year, I focused on all 8 of these to some degree. But today, I really want to focus on the ones highlighted in red, talking about the simultaneous attention. working memory, category formation, and pattern recognition. So here is the impact of cognitive overload, and frankly, this is no surprise to anyone. When dealing with the emotional toll of our own health or our family worry, too much information, too many alarms, too many phones ringing, multiple people, systems, all of these can overwhelm the nurse or the doctor in the moment. We know that it can lead to cognitive overload, and studies have shown that medical device user errors are responsible, that cognitive overload is responsible for 80% of medical device user errors, plus contribute to the more than 250,000 people dying each year from medical errors. There's forgetfulness, there's errors of omission or commission, stress, sleep disturbance, anxiety and agitation, all of those things that we see with PTSD are chronic stress, or chronic, the toll of chronic responsibility that is unrelieved and unrelenting. So this leads us to saying, okay, what can technology do? Because one of the things that I've done through my years working in informatics is, how can technology mitigate cognitive load? Because I think the traditional thinking is that technology adds to it. It's one of those things that you have to introduce into your environment. You know, we've always had these traditional notions of it has to be 5 clicks or less, it has to be intuitive this, or it has to know all those, and all of that is very important. But I think over time, as we've absorbed technology, we have to go to the next level to say, what kind of information and how do we reduce the wear and tear on clinicians? Primarily, I would say to reduce cognitive load, the number one thing that we can do is reduce the burden of memory. We absolutely cannot expect in high stress, dynamic, very not static environments, but very highly changing, highly moving environments, that memory can be stressed. And memory can be stressed beyond its ability to be retained. So when you can use technology to remind you, for an example, someone texts me their address. I don't commit that address to memory. I don't have to memorize it. I will just put it into my maps in my map app on my phone, and it will be there when I'm ready to go. That's how we use technology in our personal life. We should allow clinicians to use technology in much the same customized ways to parse information and utilize information in the moment as they need it. Keep essential information with the clinician. In other words, mobile. There's truly nothing mobile about a mobile device except the user or the wearer. And stationary information that one has to return to over and over to get the information they need can be highly challenging in a highly mobile environment. So you don't want to send all of that information to the mobile device, but you send to the clinician or the user of the mobile technology what is essential, what do they need in the moment, reminders to go back to the record. An example of that is an Excel spreadsheet. I get emails all the time with Excel spreadsheets attached to it, but I certainly don't look at them on my phone. It's too difficult. I'm afraid I will miss a discrete data point that is important. So what I do is I have the notification that the Excel spreadsheet is there, and I know I need to return to my workstation then to look at the big picture. That's what I mean by sending essential information to the clinician, and deliver only actionable information and ensure that it's provided in context. Discrete data points, again, don't do a whole lot of good except cause an added burden that the clinician now has to figure out some way to slot it into context and put it into their own frame of reference. So let's focus on multiple simultaneous attention. Nothing has brought the challenges of multitasking in the patient care environment into focus like what we've experienced over these past 2 or 3 months. We've experienced the unrelenting work of healthcare teams trying to care for patients who can go from a cough to a ventilator in 4 hours or less. The constant need to respond in the moment, the inability to plan and strategize, all of this impedes the nurse's ability to sustain attention. Nurses need tools and strategies to help them cope with a saturated work environment. We're taking OR nurses who have not worked directly with patients in ICUs or in med-surg units, and they're being repurposed into these very dynamic, high-risk patient care environments. And you can only imagine the added stress of, I don't even know the numbers to call. You know, this isn't my unit. I don't know the lab numbers. I don't know the pharmacy numbers. Those are not departments I work with in the OR every single day. So you can see the stress that comes with just trying to orient yourself to simply function. Vocera can relieve that burden by consolidating information and putting it in the context of the patient. When managing multiple patients, nurses must put multiple tasks to memory. So let me just give you a quick example of this. If we're talking about multiple simultaneous attention, software should allow nurse nudges that remind nurses, so again, relieve this burden of memory. It nudges them to enhance their workflow and support their memory. When care teams are synchronized on the same communication platform, same software, and on technology that supports the rapid delivery of information, the need to multitask is reduced. So we're going to talk about Sue, who's a pediatric nurse. She's walking down the hall with a patient. She sees another patient's call light come on. The parent is standing outside the door, while at the same time she hears an SpO2 monitor alerting, but she has no idea what room it's coming from. It's just coming from one of the patient rooms. As she walks down the hall with a patient in her arms, she's calling for someone to please help because she doesn't know the patient or if the alarm is urgent in nature. She feels anxious. And at that moment, a locked door is breached at the end of the hall, setting off a code pink or a child abduction. But she has to return to the desk to pick up her phone to call for security. This puts her in cognitive overload. She's dealing with multiple urgent tasks at the same time and is quickly shut down in her ability to respond to all of the needs at the same time. But with Vocera, if we look at a different workflow and we simplify that, she's walking down the hall with her patient. She gets a nurse call alert on her hands-free smart badge from her patient's parents saying that their son is a little uncomfortable, and the nurse responds, "I'm on my way." As she's walking down the hall, she gets an alarm escalated to her for an SpO2 alert. That patient's nurse must be busy, so Sue has the child's diagnosis, vital signs in the alarm, and she can stop and check on the patient. And for the code pink that sounds overhead, security and staff are alerted at exactly the same time on their individual device of choice, and they're able to respond immediately to the location where the infant security alarm has sounded. Managing that multiple simultaneous attention is streamlined. The technology, the software, carries the entire burden of memory, it carries the information, and it automatically accesses and addresses the individuals that need to be accessed. So let's talk about working memory. It's the ability to remember instruction or keep information in your mind long enough to complete a task. How many of you leave your office and walk to, now that we're all officing from home, you walk to the kitchen and say, now why did I come in here? And it's because you have been so deeply entrenched in the task that you were working on in your office that you quite literally forgot why you were going into another room. And you're having to go back, retrace your steps, your memory steps, and access what you were doing when you had the thought that you needed to go to the kitchen. Another example is looking for research data. I imagine many of you on here have had to write reports or daily reports for the clinicians in your hospital. And while you're writing, you're accessing information from a website, and you keep having to toggle back and forth because you're so busy or you're so entrenched in trying to get it done with the phone ringing and people coming to talk to you that you can't retain the information in your memory. So you just keep going back and forth and back and forth and back and forth. That is where working memory is challenged and becomes a cognitive overload when people just finally say, I can't do this anymore. I absolutely cannot retain one more bit of information. As tasks change and information moves into high-stress, fast-paced patient care environments, multiple demands are placed upon working memory. it becomes taxed beyond its capability to function. And Vocera, once again, can carry that burden of memory as needed. Let's look at this one. Karen is a nurse on med-surg. She's covering for her co-worker Carl while he's on break. She listens to a brief report about his patients and jots down some information. She'll need to turn one of Carl's patients in about 20 minutes because he's an elderly man with serious pressure ulcers. She attempts to commit that to memory, says to herself, turn the patient, turn the patient. And while Carl is on break, another one of his patients calls out requesting pain medication. Again, Karen is telling herself, don't forget to turn the patient, don't forget to turn the patient. But now she has another patient requesting pain medications. Because she does not know the history, she's going to have to go back to the desk to find out what medications this gentleman is on. So she goes back to check the EHR to see if it's time, what the medication is, and she pulls out her notepad to make some notes, and in error leaves her notepad at the desk. And she goes back to deliver the medication. More than 20 minutes has passed. Carl comes back from lunch. It's been 45 minutes. And now the trust is broken between the coworkers. The patient has been compromised, and Karen feels terrible because the stress of the environment, the load of the environment evacuated her memory, if you will. So now let's look at Vocera simplified. Karen listens to Carl's report. She signs on his patients on Vocera so that she can see the history and the information about the patient. She can get the alarms and they come to her directly. She gets diagnosis and vital signs, and she can also record for herself a reminder by simply saying, hey, Vocera. She can record a reminder to turn the patient in room 304. And as she's delivering the pain meds, even though she doesn't have her notebook with her, she doesn't have to go back to the desk. She gets the diagnosis, the medications, and the pain score all on her mobile device, and is able to deliver pain medications, saving steps to the desk and just going to the medication dispensing machine, and then also receives the reminder in the 20 minutes that she needs to go turn the original patient with the pressure sores. So, just a couple of more of these category formation. Category formation is something that all of us struggle with in environments like we've been in lately. Patients arriving at the hospital in endless succession without enough beds or enough equipment. Some of you have likely lived it. The rest of us have watched it. The struggle to access and categorize inconsistent and changing symptoms can challenge the busy, stressed healthcare team who's trying to carry out the urgent task. The nurse, one of the qualities that nurses have to have is the ability to organize knowledge. They have to organize information, to assemble all the lab work, to read all the notes, to look at every relevant detail regarding the patient, and to put that patient status picture together so they can either give a report off to the oncoming team member, be able to communicate with the physicians to give the full story. The nurse is truly the hub and the center of the wheel, because all information will flow through them to go to the patient. The nurse with 4 patients might be dealing with 8 to 10 physicians, specialists and subspecialists who change throughout a shift. Being able to know call preferences, do I page this doctor? Does this doctor prefer their personal cell phone? Does this doctor want me to call an answering service? Do I page overhead? Nurses have to absorb and memorize all this information for all of these different care team members, and sometimes there's just not enough memory capacity, and the environment is so complex, it can really add to their cognitive burden to constantly be looking for that information and trying to access that information appropriately. So let's look at how we can form categories for the nurse and access that information and streamline that workflow to release some cognitive burden. John is a nurse on the cardiac step-down unit. He has 3 patients. And the central telemetry monitor tech has called the unit twice now to try to alert him that Tom Perkins was experiencing VTAC. The first time he was talking to the lab on his unit or desk phone, so his charge nurse got the call on the red phone that he didn't answer and went ahead to check on Tom. The second time he missed the call because he was changing an IV. But the monitor tech called right back and went to check on Tom. After his assessment, he decides to loop in the resident. He asks the unit clerk who's on call, and after a few minutes of figuring that out and then finding the resident's pager number, John successfully pages the resident to the unit. The resident calls back, but John's busy with another patient, and eventually the resident just comes to the unit to see what's going on. So while I was going through that and that 45 seconds there, that probably happened dozens of times across the country. And it's going to happen thousands of times before this day is over or this shift is over. The constant stress of trying to get the right person with the right information at the right time in the preferred way of communicating is a stress that we can so easily remove from care teams. If we simplify that care workflow, John gets an alert on his Vocera Vena app for Tom Perkins, who's in VTAC. He goes to assess the patient, decides to loop in the on-call resident. He locates the resident for Tom Perkins in the app by accessing the care team solution for Tom and looking at who the on-call resident is, and simply forwards the information, including the EKG strip, to the resident so they can talk within 60 to 90 seconds about the situation with the patient, rather than all of the back and forth that you see on Tim's side. Again, reducing the cognitive burden of the hunt and peck. So let's look at our final workflow, which is pattern recognition, and probably the most complex of all the cognitive capacities in recognizing patterns of behavior, or patterns of presentation, I should say. Initially with COVID, the symptoms we expected to see and we were all looking for was cough, fever, and shortness of breath. Then suddenly they started presenting with chest pain or GI distress and headaches and low-grade fever. One of the ER physicians in my community, we were having a conversation, and he said, I had a patient present with a toothache. He said that was his one single complaint. It was an excruciating toothache, and he tested positive for COVID. He said, I've just decided to test everyone who comes into my ED, and the man ended up in the hospital. So it's really been quite dynamic and challenging for everyone. And a nurse who's on hour 40, 50, 60 of a very busy week might receive a patient presenting with GI distress and think, someone else had that symptom and they tested positive. Who was it? Where did that happen? Where is that coming from? In pattern recognition, the mind matches information from a stimulus with information from a retrieved memory. It's that same thing that happens when you're watching a movie on television and you see an actor and you think, I've seen that actor before. What movie were they in? And your mind then starts the process of, I've had a stimulus. Now I'm trying to retrieve a memory and match that. This retrieved memory is telling me I need to match it up with something that I recognize. And that happens dozens of times a day in healthcare. So in pattern recognition, communication software can help categorize that information. It can relieve the nurse of the burden of pattern recognition. If a patient presents with an unusual symptom or an unusual characteristic, a nurse with Vocera Vena smartphone, the app, can easily access information about other patients, see their diagnoses, their vital signs, and how they presented. They can see patterns in the information and patterns in the behavior. And probably the most well-recognized one of this would be, we've got Nancy's a nurse on Med-Surg who has Mrs. Jones. She's an 85-year-old with CHF, and she's been Nancy's patient for 2 days now. At the same time, Nancy has 4 other patients. Yesterday, Mrs. Jones was talkative, but today, Nancy hasn't had a lot of time to spend in the room. She knows she's sleeping a lot. and she didn't really recall what day it was. So Nancy requested a CBC and a urine sample for testing be sent to the lab because she thought her urine looked a little bit cloudy. So she sends all that onto the lab. Then she asks, the HUT calls and says that the lab has called about her patient. So now she's still trying to match up vital signs. She asked the CNA, what the vitals were they recorded, what was her blood pressure, what was her pulse. I need to check this out. She makes a mental note to check on her more frequently and asks the HUT to be sure that she gets those lab results as soon as they come up. Unfortunately, in an hour, Mrs. Jones is unresponsive and septic. While she was waiting for all of this information, accessing multiple resources, trying to get the information she needed to understand the condition of Mrs. Jones, plus care for her other 4 patients, the cognitive burden of that just made it where she was not able to follow through in as timely a manner as she probably would have if she had had the information coming directly to her. So let's look at the workflow simplified. Nancy's taking care of Mrs. Jones for the 2nd day in a row. She gets a critical lab result on Vena that indicates Mrs. Jones has developed a UTI. As the CNAs do the vital signs and enter them into the EHR, a sepsis alert is sent to Nancy, the charge nurse, and the rapid response team through a clinical integration with a sepsis monitoring system, the EHR and Vocera. The system is able to connect key indicators of sepsis to enable early detection and treatment for Mrs. Jones, ensuring a preferred outcome for this patient rather than an outcome that none of us would like to see. So that's just a brief overview of those 4 cognitive capacities and how it could perhaps work in healthcare and perhaps a solution to mitigate that and provide simple tools that ensure that the nurse can continue to do their job and have the support that they need with device and software. So let's talk about a 3-point strategy to strengthen resilience. Cognitive science has provided this foundation. I will tell you that the whole science of cognitive strength, cognitive capacity actually comes from education. It was really designed to understand how people learn, how they are able to retain information in the learning environment. But as we've progressed on learning more about the science and the discipline of it, it certainly is applied to all of us. Whether we work in high-risk environments or low-risk environments, we all experience it. And we all deal with the capacities that we have and when we're stressed and strained to breaking points. So as I worked through this, I thought, what can we do to strengthen resiliency? How can we use technology available to us? And how can we streamline or smooth out the bumps in these workflows? Because frankly, it's the constant gnats around the ankles, if you will, of the environment that layers on and layers on and layers on until clinicians reach this point of cognitive overload, and then all of the stress that goes with it. Nurses working outside their own department, nurses working with equipment that they're not used to. When we talk about nurses who are overloaded from the highly stressful environment they've worked in, it really is just all of the details of the things that they don't know or they are uncomfortable with or they can't get the information they need or they're having to document more information than they should in the moment, multiple different sources, and having to glue all of that together to get the picture or the support that they need. That's what creates the frustration with the environment. So the first thing I would say is address the strategic delta between documentation and communication. When caregivers are moving through the hospital trying to manage critically ill patients at warp speed like they have been doing, and the patients just keep coming, information can't be lodged at a stationary place. It has to be able to move with them. Care teams are mobile, and information has to be mobile too. Hospitals rely on the EHR as a repository of information. I've been on calls with nurse leaders all over who've talked about having to just abandon added documentation, just saying what is critical in the moment and what are we using now. And I do believe that coming out of this, some of the lessons learned are going to be around what is essential to take care of these patients and what will never come back into the workflow, because, when the rubber met the road here, it wasn't needed and it added to the burden. Documentation and communication are essential. One does not work without the other. Yet today, no single platform can address both. There is a documentation platform and there are communication platforms. Documentation on the patient resides in the EHR, but for it to be communicated, it has to go to an endpoint where the nurse can receive it. You can't have a communication platform without an EHR. You can't have an EHR without a communication platform. As they work together, you need to have the ability for clinicians to summon stroke teams, critical teams in the moment, sepsis teams, all of those people that need to be managed, for patient security or violence against healthcare workers, to be able to summon someone in the moment that requires the ability to talk to each other. We cannot conduct the business of healthcare through texting and documentation. We have to be able to talk to each other, and we have to be able to provide devices that allow people to continue to do their work and talk, such as hands-free wearables, enabling nurses to have both of their hands to care for the patient rather than constantly having to manage a phone is critical to streamlining the workflow. And that takes me to point two, give clinicians control over how they communicate. I've been a nurse for a long time, and I can tell you in the hospital there was never a point where anyone asked me how I preferred to be contacted. No one said, do you want me to call you on, in the unit, or do you want me to page you overhead? I just had to absorb it and paste the picture together. This crisis has made it clear that hospitals need to empower nurses to control the way they communicate. Nurses thinking, I need to find a physician, I need to know who's on call, but I just came on call and I don't have all that information. This is not my normal unit that I work in. We have to remove the burden of constantly having to adapt to varied preferences. No nurse should have to ask, does this doctor want to be paged? Does the other one demand I go through an answering service? Or, how do I call the department I need to reach? Put everybody, physicians, nurses, ancillary staff, on the same communication platform. Whether they communicate by texting or by calling, everyone needs to be using the same software system in order to communicate efficiently and in real time. Select a communication platform that can work for everybody and drive usage behavior. Nurses and physicians do communicate differently, and we have to respect that. But they can use the same software. They can use the same nomenclature, the same abbreviations, just like they all use the same email format, the same framework. They can use the same communication framework. So nurses don't have to be the ones who work in and out of systems. Me paging physicians who are on or texting a physician who's on a separate texting software platform is just another added burden to what I already have to do, because now I have to come back and figure out a way to call somebody or figure out a way to translate the information that's in the text message into the record, those sort of things. So point three is use software to enhance workflow, not distract from it. Those of you who know me know that I've been on a mission for about 20 years to simplify care at the point, to simplify the nurse's life at the point of care. I truly left working in a hospital in administration because I was so frustrated by the lived experience of the nurse trying to patch together disparate systems and having to use technology that really did not work for them in the moment. And what I have seen over the years is that if you give clinicians something that actually works for them, they adopt it. And we can look all across at medical devices or features on beds or whatever. We can see software programs that really work. And then we can look all across the system and see systems that have been abandoned, that have been picked up and deserted over and over, and the frustration that goes with that. So when I was completing my doctorate, I wanted to try to understand what causes nurses to adopt a software or to adopt a technology. And so I did research on, I wanted to understand just simply, do nurses find texting for the purpose of patient care useful? That they think it's useful. I narrowed it down to a very narrow scope. And what I discovered using several different models is that the notion we have that it has to be simple and it has to be, you know, 5 or less clicks or whatever was so low and statistically that it was absolutely, those two were statistically irrelevant. What rose to the top as being statistically relevant was context. That if the technology works within the context of their job, if it enhances their workflow, they will use it. If it causes them to have to create workarounds, if it causes them to have to either add steps that are unnecessary or take away steps that are necessary, they will abandon it. And as many of you know, in healthcare, if you introduce a technology and that introduction does not go well, they tend to abandon pretty rapidly. There tends to be, throw up the hands, I'm not doing this. But if it works, they will fully adopt it. And so that is, I do believe that when we create softwares and technologies for the point of care, that our job is to understand the workflow and then find ways that we can smooth the bumps in the workflow, or we can fill the gaps in the workflow, not change it. I think physicians and nurses are really quite brilliant people, and they fully understand what they need to do and how they need to care for their patients. And so for us to kind of waltzing in and say, we don't want you to do that, it can be quite disorienting, and it's something they will not adopt. So what we try to do then is send clinicians in to understand exactly what is your workflow, exactly how do we need to enhance this. We assess to understand clinical practice. We create workflows to support the practice and find ways to fix what's broken and shore up areas of weakness. And EHR's communication applications work best within the documentation side of the EHR, but there is a need for role-based calling. There's a need for urgent call teams like stroke or STEMI teams. There's no escalation of communications or notifications in a static stationary system. You cannot communicate in a hospital entirely on a documentation system. It's impossible. Efficient clinical workflows require purposeful communication and purposeful information in real time. If you need to communicate that urgent information, you have to have a communication strategy. And that's why I would say one of the most important things that we can do right now is to provide a communication strategy along with, when we start to look at what is our next strategy, how do we plan for the next wave of the pandemic? Communication should have its own line item. We need to look forward around the world. We're still sorting through the lessons that need to be learned. Not any one of us has all the answers. What we do know for sure is that we're forever changed. Just like with everything else, we can't always control what happens, but we can control how we manage and we respond in our preparedness. Now's the time to manage healthcare team members who are trauma survivors and will experience PTSD for a long time to come. How do we ensure that we don't run out of supplies? How do we ensure that we don't intentionally spread disease or infection? How do we ensure that communication, which is the very backbone of patient care, is no longer an afterthought, are tacked onto another system, but is in fact a strategy and system of its own. Communication tools must be part of PPE. We've all seen nurses with multiple communication devices hanging off their scrubs or in their hands or held near their face. These devices must be cleaned between every patient, which consumes time and supplies. A wearable communication device such as our badge, the Vocera badge, can be worn under PPE. It allows for continued communication and receipt of patient information in real time, and it's essential to protecting the nurse and facilitating the flow of information. Some of you will continue to operate in crisis mode for a very long time to come. Others are seeing a break in the stream of COVID patients. What was easy to shut down is now very, very difficult to bring back online. The conversations I'm hearing around how do we move forward to bring our elective surgeries back online, and how do we slowly re-enter the world that we once had. Recommendations for planning for the next time are starting to surface, and certainly financial worries have begun. There's no doubt about that. We don't know for sure what the future holds, including how long we have before the next outbreak or the next crisis. But what we can do is define what is essential, ease the burden where we can, and we can use the lessons learned to plan for the future crisis that impact and are straining our healthcare systems. Our teams at Vocera are here to help, and we want to hear from you. We have done remarkable things over the past few months. We have developers ready and willing to create unique and customized workflows that enable you to stand up beds in places that don't have nurse call. We can enable you to create unique workflows to support dividing COVID from non-COVID sides of the hospital. We can do all of these things, and we are ready and willing to support you, and I would love to hear from you. So I thank you for your time and attention and your commitment to be here to talk about this very important issue. Kathy, I'll turn it back over to you.
Well, thank you so much, Dr. Collins. That was absolutely fantastic and quite educational for me as well, I'm sure, the audience. You know, there was a day when I worked at the bedside, and I remember many days when I left for home mentally and physically exhausted, caused by many of these experiences that you just talked about and called out. This is such an important topic for our leaders that we really need them to help us address that, and I'm thrilled that there are opportunities and options for that. Folks, we're going to move into the Q&A section now. So if you have questions, please enter them into the Q&A portion of the platform. In the meantime, during your session, Rhonda, there have been a couple questions that have come through that I'd like to tee up for you. So you ready?
I'm ready.
All right. This one I think you can answer. Okay, of course. Well, that was a long conversation. The first one is probably pretty simple for you to answer. It says, you may have addressed this, but can this communication tool be incorporated into the patient call system?
Absolutely. Yes, we can integrate from any patient call system to the device of choice. We most frequently see nurses prefer to be hands-free for obvious reasons. Nurses need to be able to use both of their hands to take care of a patient. But absolutely, we can integrate nurse call, medical devices, you know, other lab systems. We can have conversations about pretty much anything you want to integrate.
Great. That's great. So this is an unusual question, Dr. Collins, and might take some thought for you. One of our participants has said, I teach approximately 90 students final med surg courses, and they attend 12 clinical sites. How can I make it simpler for them to work as final semester student nurses in their clinical sites?
That's a huge challenge, and I think what I would do first of all is look for systems in the clinical sites in which they work that are similar. And I'm assuming, I'm going to make the assumption that you're saying that they have to rotate from site to site. But I think part of what these students need to address when they go in and get the information on their patients that they're going to care for the next day and start putting together care plans and all of those things that they have to do. Some of the work that they need to do is understand what kind of communication system do you use, where do I find the numbers that I need to call, how do I access the information I need, because I think that's no longer just something that you'll figure out when you get there, because it's so different in every hospital, and it is essential to providing good care. Communication, again, is backbone. So that would be my suggestion to reduce the cognitive load of the day that you show up, is to add that to the information that you need to find out. Patient diagnosis, patient vital signs, patient medications. What kind of communication system do you use in this unit so I can understand how to use it?
I love how you answered that. This is a technical question, Dr. Collins. It says,
well, I may have to call somebody technical.
I think you know the answer, though. The Vocera, okay, you ready? Does the Vocera device require internet access?
I can answer that. The wearable device requires Wi-Fi. If you have the app on the smartphone or the mobile phone, then that can work off of Wi-Fi or cellular. The badge does require internet.
Okay, that's great. So here's another one. Do you think the COVID-19 pandemic will help hospital leaders see and understand the issue of cognitive overload?
Well, I know one thing for sure. I know that this pandemic is causing all of us to go back to the beginning and parse out what is essential and what is non-essential. I think that all of us, again, as I said, are forever changed, and all of us are looking at ways in how we deliver our service or our care or our business differently. And I think part of that is the load that you put on the workers. It's, you know, anybody who's listening in, you may not work in a hospital, you may teach, you may work in business, but you have to think about the load or the burden that you put on the people that report to you or that you are responsible for managing, because that's what's going to determine their ability to stay and sustain through these changes through the long haul. Change is highly stressful, and it's very difficult to manage over time. And when it just feels like nothing ever settles, that the ball is always in the air, that will continually and over time increase cognitive burden. And it will build and it will build and it will build. And then all of a sudden you start losing good employees because they can't deal with the pressure of the environment anymore, or the unexpected workload in the environment anymore. So I would suggest that if you are not thinking about it, you need to think about it. And it needs to be something that all of you put on your agenda to talk about and understand, and how you can mitigate that, whether it's through technology or through process or protocol, conversation, work, staff mix, all of those things that go together to create a sustainable work environment.
I love it. We're getting close to the end time. I think we wanted to end a little bit early to give everybody a chance to take a break and get ready for their next meeting or webinar or conference.